Reflexes are involuntary contractions of muscles or muscle groups in response to a stimulus. When testing reflexes, they are classified into 3 different categories. Those categories are deep tendon reflexes, superficial reflexes, and pathologic reflexes. Testing reflexes enables the examiner to assess involuntary reflex arcs in order to determine if there are any neurologic disorders or nerve damage. The bicep reflex is elicited by striking the bicep tendon, located at the antecubital fossa. The patient's arm should either be rested on their lap or supported at the forearm by the examiner. The examiner will place their thumb against the tendon and strike the thumb with the reflex hammer. A normal response is flexion at the elbow and contraction of the bicep. To elicit the brachioradialis, the patient's arm is supported or placed on the patient's lap and positioned with the thumb side up. The examiner will strike 1 to 2 inches above the wrist to elicit a response. A normal reflex is flexion and supination of the forearm. To assess a tricep reflex, the examiner will support the patient's arm so it is flexed at the elbow and hanging freely at the side. The examiner will strike the tricep tendon located 1 to 2 inches above the elbow. A normal response is extension of the elbow and contraction of the tricep. In order to elicit an Achilles reflex, the foot is dorsiflexed at the ankle with the help of the examiner, and the hammer strikes the Achilles tendon. This reflex should produce plantar flexion. If this does not occur due to lack of relaxation, instruct the patient to kneel on a chair or elevated flat surface with the ankles hanging over the edge. This places the ankles in dorsiflexion and reduces any muscle tension. Again, the Achilles tendon is struck and a plantar flexion should occur. The patellar reflex is elicited by striking the patellar tendon just below the patella. The patient may be sitting or in a supine position. If supine, the examiner will support the legs to facilitate relaxation of the muscles. A normal reflex is contraction of the quadriceps and knee extension. When reflexes are hyperactive, clonus may be elicited. In order to assess for clonus, place 1 hand under the knee to support the leg, then dorsiflex the foot towards the client's head. When the foot is dorsiflexed, it may continue to beat 2 or 3 times before it settles into a position of rest. To elicit the deep tendon reflexes, proper use of the reflex hammer is most important. You must hold the hammer loosely by the handle with your thumb and index finger to allow for a full swing of the hammer. The extremity is positioned so that the tendon is slightly stretched and then struck briskly with the head of the hammer. Wide range of responses is considered normal, but most importantly, the reflexes must be symmetrically equivalent. Valid findings depend on several factors: proper use of the reflex hammer, proper positioning of the extremity, and a relaxed patient. When documenting, deep tendon reflexes are graded on a scale of 0 to 4, 0 being no response, 1 being diminished or hypoactive, 2 being normal, 3 being increased but may also be interpreted as normal, and 4 being hyperactive, also referred to as hyperreflexia. These deep tendon responses and plantar reflexes are commonly recorded on stick figures. For the plantar response, normal would be represented by a down arrow and upward if the response is abnormal. The major superficial reflexes include corneal, palpebral, gag, upper and lower abdominal, cremasteric in men only, and perianal. The most commonly tested reflexes are the corneal and gag reflexes. The corneal reflex is tested carefully using a clean wisp of cotton and lightly touching the outer corner of each eye on the sclera. The reflex is present if the action elicits a blink. A stroke or brain injury might result in loss of this reflex, either unilaterally or bilaterally. Loss of this reflex indicates the need for eye protection and possible lubrication to prevent corneal damage. The gag reflex is elicited by gently touching the back of the pharynx with a cotton-tipped applicator, first on one side of the uvula and then the other. A positive response is shown with gagging and elevation of the uvula. An absent response on one or both sides can be seen following a stroke and requires careful evaluation and treatment because it can lead to aspiration.